It's good afternoon there, right? It's afternoon,
yes.
correct?
Increase the sound.
Okay. Can you hear me in this? Can you hear me clearly?
Yeah, very loud and clear. This is Vijay Trayan, Saibal.
Vijay, how are you?
Pretty well fine here.
Good. So I'm going to speak about two lectures. One is on transcatheter mitral valve repair using the MitraClip, just indication and case scenarios. And then if I have time on WATCHMAN, okay? So transcatheter mitral valve repair using the MitraClip is an established treatment option for selected patients with non-rheumatic MR. It's effective in selected patients with both primary and secondary MR, and there's evidence of safety and durability. New data has confirmed its efficacy on secondary MR. Now, these are the new generations of MitraClip. You have the NTR and the XTR, and the difference, fundamental difference between the two clips is that the XTR is about 5 millimeters longer than the NTR, so that it allows you to an expanded population of treatment, mitral valve pathologies that are going to be treated. However, in India, there's been only a handful of cases. I was there in all those cases, and the only available technology that was available in compassion was the NTR. And based on my experience, I don't think you need XTR in India because the valves are quite small. So I think NTR is okay. The concept of MitraClip is it reduces MR by coaptation of leaflets. It creates a tissue bridge and limits annular dilatation, and it restrains the LV wall by limiting LV dilatation. So globally, actually now there's over 80,000 cases worldwide, and about 17,000 patients, and 17,000 patients are studied in clinical trials, and over 1,000 publications. So it's a very well-established treatment. And this is just to show you the dimensions. So let's start with a few words on case selection. Severe MR who are symptomatic or asymptomatic with evidence of early dysfunction. Etiology has to be non-rheumatic MR, and this is very emphasized. It's not effective in rheumatic MR, and it's good for degenerative or functional with a suitable anatomy. And the risk status, ideally high-risk surgical patients or patients where surgery is not indicated. These are the cases. Suitability, this is the ideal case. Non-rheumatic MR originating from the central two-thirds of the valve. The etiology can be either degenerative or functional, and there's got to be sufficient leaflet tissue for mechanical coaptation. And the flail gap should be not greater than 15 millimeters, and there should be some touching, and the mitral valve area should be ideally greater than 4 square centimeters. In valves in India, where the patients are smaller, even up to 3.5 square centimeters, okay. Now, these are the expanded indications. You can have an A1P1 disease. You can have A3P3 disease. You can have patients with end-stage heart failure with MR. You can have patients with recurrent MR following surgical repair, hypertrophic obstructive cardiomyopathy with SAM and MR, or even low-risk patients with MR. So these are the expanded indications. These are an example. I'm just going to show you an example of a 67-year-old male who was short of breath in NYHA Class 3. Here is a patient whose LV injection fraction was 38%, a very large ventricle, mild TR, moderate RV dysfunction. But what is important is to see it's a mixed mitral valve disease. You see that? Where the patient actually has a flail posterior leaflet, but in addition has LV dysfunction because of progressive heart failure and enlargement of the heart. So this is a very bad patient, advanced patient. And obviously, if you can see over here, there's a flail posterior leaflet, but there is a large gap between the two leaflets. And therefore we knew, and the ejection fraction is down, and we knew therefore with the regular clip, we would not be able to grasp the leaflets. So this PA pressure was very elevated, 88/40, mean of 60, cardiac output was 3.5, so the pulmonary vascular resistance was 9 Wood units. So he was turned down for mitral valve surgery because of low ejection fraction, severe pulmonary hypertension, RV dysfunction. He was turned down for cardiac transplant because his PVR was greater than 9 Wood units. He was turned down for the regular MitraClip because there was too wide a gap. So the only option was to use a MitraClip XTR. So over here you can see we managed to grasp the lateral portions of the mitral flail with one clip, and you got a good, reasonably good result. And then once we grasped the lateral part, the next part becomes easier. And then we did a second clip. You can see we do two clips, and there's only trace MR medially. And there you can see the a 3D end face view showing two clips and the entire flail segment taken care of. So that's an example of a degenerative MR patient. Now, second is I'm going to show you a patient with functional MR. This is a 65-year-old male with severe shortness of breath and fatigue for 1 year. He had ischemic cardiomyopathy since 2014. He was admitted with heart failure for 6 months, for the last 6 months. He was treated for heart failure team and was in appropriate medical treatment. And in spite of the appropriate medical treatment, he still continued to have severe MR. So what I see is baseline is ejection fraction is 25%. You can see a very poor LV function. You can see a mitral regurgitation, which is severe. And you can see that even the leaflets are a little bit calcified. When we did the TE, we can see how this is clearly functional MR from the central part of the mitral valve. And you can see over here, there's a bit of calcium here, but the leaflets are not coming together because of pure functional MR. Very different from the previous case. This patient was enrolled in the QUAP trial and randomized to getting the clip. And then we managed to put one clip right in the middle of the valve, reduce the MR, see that to only mild, and you can see a very nice tissue bridge, bridging the posterior and anterior leaflets, and only a small medial jet. The gradient was 3 or 4, so we didn't put any more clips. This patient remained in NYHA Class 2, no heart failure admissions. In July 2008, NYHA Class 2 with only mild MR, no change in medication. So he's now 2 to 3 years out with no heart failure admissions. So this is an example of a patient with heart failure who did so well. Now, the indications of the MitraClip, it's FDA approved for high-risk primary MR with a suitable anatomy. And the FDA recently approved, based on the QUAP trial, for patients with secondary MR who have significant MR in spite of adequate medical treatment, where the ejection fraction has to be greater than 20% and the end systolic diameter should be less than 70 centimeters, or 77 centimeters, not 70 centimeters. So this is actually quite a good indication, and it's a very broad indication for MitraClip now. And so we said the evidence comes from the durability, 5-year Everest 2, and the randomized trials in secondary MR. So the Everest 2 5-year data shows you that if you take patients who are surgical candidates, there is no difference between survival between the MitraClip and the surgical patients over 5 years. And then if you look at redo surgery, you can see that about 20% of patients required a surgery in the first 6 months. But after 6 months, between 5 years, very few patients required surgery. That means if you are stable at 6 months, it's unlikely that you will require surgery at 5 years. So now we want to show the Mitra Fr study. Now we're going to function secondary MR. And in the Mitra Fr, it's a secondary MR study. We wanted to evaluate the role of MitraClip versus medical therapy alone in patients with heart failure and severe secondary MR. And the primary endpoint was a composite of all-cause mortality and unplanned rehospitalizations over 12 months. And these patients were ejection fractions as low as 15%, severe secondary MR, but the ERO was cut off as 0.2, and they were not eligible for surgery. And what they found is that when they randomized these patients, 152 to clip, 152 to control, they had a lot of great follow-up on these patients. They found that the primary composite endpoint at 12 months, there was no difference in heart failure or mortality. And so this was very discouraging for patients with secondary MR. And this led to the COAP trial. Oh, I'm sorry, I didn't have the COAP trial up here. And in the COAP trial, so let me show you the COAP study. This was a much larger study where 665 patients were randomized to either MitraClip plus GDMT versus GDMT alone. And you can see the endpoint in the study was heart failure admissions, and the secondary endpoints was mortality and other functions. And when you see all heart failure admissions in 24 months, there were 283 admissions in 151 patients who got medical treatment alone. And if you look at the patients who had the MitraClip, you see a dramatic reduction of heart failure admissions. And this separation of the curves occurred as early as 1 month. And this is a very dramatic change, which has not been seen in the literature before. In fact, the number needed to save one patient from a heart failure admission is only 3 patients. And that shows you 3 patients to save one heart failure admission. And then if you look at the mortality curves, you can see the same thing, that patients actually had a 17% improvement on mortality after MitraClip. So what we concluded is that MitraClip is a safe and effective and durable treatment option for selected patients with primary or secondary MR. Most patients are high surgical risk patients, and new data supports the improvement of survival in patients with secondary MR. Case selection is critical, and in the future, new trials are addressing the role of MitraClip in tricuspid regurgitation and also in low or moderate risk patient primary MR. Thank you very much. Any questions?
No, that's great, Saibal. I think that in the interest of time, let's have you go to the next talk, and then we could maybe combine if there are questions at that point. It's good to see your face, though.
You can see my face?
I can see your face.
How are you?
We're good. The good news, we can only see your shirt, so, you know.
Yeah, you don't know what I'm wearing below.
Exactly, exactly.
And this is 1 o'clock at night. So this is the WATCHMAN device. I'm just going to see a device evolution, patient selection, and tips and tricks. And this is what an atrial appendage looks like. You can see this is the trabeculated part. This is the smooth part, and this is the true anatomical ostium, and this is the echocardiographic ostium. And if you look by echo images, this is the true anatomical ostium. This is the echocardiographic ostium. That's the body, and that's the neck. And the reason why I'm trying to bring this in, there are 2 sets of devices. One is the WATCHMAN device, or the WATCHMAN-like device, which really blocks only the body of the appendage, and the Amplatzer cardiac plug, which blocks both the body and the neck. But we particularly think you don't need to cover both, because once you cover the body, the rest is actually smooth, so you don't really need to cover both. Now, the WATCHMAN closure device, the 2.5, consists of 5 different sizes. And you can see over here, it has barbs in the distal part of the appendage device. And the top half is covered with nitinol, and then it's got a fabric. And then you have a screw over here. Now, there's a new generation of watch called WATCHMAN Flex, which is going to be available soon, hopefully. And you can see over here, it's actually a shorter device. It's got multiple struts, and the ends are rounded. And this is really helpful because this prevents perforation. And also, this device can be easily recaptured and used. So that's the Flex versus the WATCHMAN 2.5. Now, here's an example of a patient selection. You should have non-valvular AFib at a risk of stroke with a CHA2DS2-VASc score of greater than 2 for men and greater than 3 for women. And the candidate should be ideal for at least a short term of anticoagulation. At the anatomy, there should be no LA thrombus, and the size and depth should allow placement of a device. These are the steps we go through the assess. So I'm going to go to the first step is assessment of the LA by TE. We take 4 separate views, and we measure the appendage in its depth and width. And then we decide to choose a diameter of a device which is about 20% larger than the maximum size. So for example, if it is like say 20, I would use a 24 millimeter device. Or if it's 24, I would use a 27 millimeter device. Now the transseptal puncture is critical in the procedure, and we try to do a transseptal puncture which is low and posterior. So this is quite low and also posterior. And this allows the sheath to go coaxial with the atrial appendage, because if you're anterior, the sheath will go in an oblique angle, the device will be deployed wrong. We position the sheath in the left atrium with the help of a pigtail catheter. So we advance the pigtail catheter into the left atrium appendage, and then using the pigtail as a rail, we advance the sheath in. This is what prevents perforations. And then once you're inside there, then you can do a deployment of the device. And you can see over here, you make sure that your areocoral in the plane of views. And then this is the sheath deployed at correct position. And then the deployment of the device is you gradually retract the sheath as you are allowing the device to expand. And then once it's completely expanded, you can see, you can inject contrast, and you can see that there's contrast going through the device, but not on the sides of the device. And then once you've deployed the device, you can see that it's very well sealing the appendage. And then you go ahead and look at it in different views, and you can see there's just a small shoulder, which is okay. And then you do a final assessment. You read these 5 criteria called the PASS criteria: position, anchor, size, and feel. This is the WATCHMAN Flex. You can see that the WATCHMAN Flex is got multiple sizes. 35, and you create a ball. And here's a case where we are creating a ball in the appendage. This is the deployment of this pigtail angle. And then over here, we're deploying the device. I hear some music, you know, and that's the device deployment. Can you hear me?
Yeah, we can hear you.
Yes. And so based on this, there are about 600 patients that are embolized. The embolization is very low. The peri-device loop is extremely small. It's recapturable, reusable, and less trauma for the device. The new generation WATCHMAN has got major advantages. Patient selection is critical. Attention to detail and deployment is critical for the success of the procedure. Thank you very much.
Saibal, thanks so much for that. Any questions from the audience? Maybe just a brief word on, you know, for patients that are not candidates for any anticoagulation, because that always comes up. Are you using it?
Yes.
What studies are needed? Are those studies enrolling? What's the status?
Well, in Europe, most of the cases that are done are patients who are not candidates for anticoagulation. And usually after the procedure, they just give them dual antiplatelet therapy. But in the US, officially, all patients should at least be eligible for short-term anticoagulation. And therefore, there's a clinical trial called the ASAP II, which is randomizing patients to no antiplatelet therapy or just single reagent versus WATCHMAN plus antiplatelets. And that trial is going slowly. And if that trial is positive, it'll prove the concept that it's a good device for people who cannot take anything at all.
All right, thank you so much, Saibal, and thanks for doing these talks today. It's great having you. We're going to actually take a break for lunch. It's good seeing you, and hope to see you again soon.
Thank you.
Yeah, thank you. Thank you, Saibal.
You're welcome.